So good evening all, and welcome everybody to IRIA Kerala PG case presentation series on ovary and uterine radiology in association with JournoMed. Towards this, I welcome Dr. Gomati Subramaniam, President Kerala IRIA, Dr. Rijo Matthew, Secretary Kerala IRIA, and Dr. Ramesh Shenai, Program Coordinator. And today our expert faculty is Dr. B. Vijayalakshmi Devi. She is Professor and Head of the Department in Sri Venkateswara Institute of Medical Science, Tirupati. I welcome Madam.
Thank you, sir.
And today the program is being moderated by our President herself, Dr. Gomati Subramaniam. And now over to Dr. Gomati Subramaniam for introducing the speaker. Over to Madam.
Okay. Good evening. On behalf of Kerala IRIA, we are today with our genital system, mainly of the ovary, Dr. BG, who's HOD in Sri Venkateswara Institute of Medical Science, was a faculty of Manipal, who worked there for 5 years, and she joined this institute 2005. She's her main interest in neuroimaging and oncoimaging, and she has a lot of research papers and a lot of awards. She's a postgraduate teacher and undergrad teacher also. She's very good in teaching, and she's examiners in various institutes also, and various state and in university. I welcome you, Dr. Vijay, to take over this platform. And we have two residents, Manasa and Sana from Sri Venkateswara Institute of Medical Science. I welcome both of them also. Over to you, Dr. Vijay.
Thank you, ma'am. At the outset, I would like to thank you, Kerala IRIA State Chapter, and especially Dr. Gomati ma'am, for giving us this opportunity and platform to present and showcase our cases. So thank you very much, ma'am, once again. I would like to call upon two of our PGs, one after the other they will be presenting. One patient is a young female patient. Dr. Sana will be presenting, followed by that in another elderly perimenopausal female patient. Dr. Manasa will be presenting them. They will give a brief clinical details and imaging they will showcase, and then they will give a brief discussion of each entity, ma'am. So now I'll call upon Dr. Sana for her presentation.
Good evening, everyone. Shall I start, ma'am?
Yes, ma'am. You can share your PPT and then start presenting.
Yes, ma'am.
Go to the first slide.
My case presentation is about a 20-year-old female patient who presented to gynecology OPD 1 year ago with the chief complaints of history of pain in the left iliac fossa for a duration of 5 days, which was sudden in onset, intermittent, and it was associated with nausea and 5 episodes of vomitings. And on examination, there was fullness in the left iliac fossa, there was guarding and tenderness. She was evaluated with ultrasound outside, which showed bulky left ovary with peripherally arranged follicles and central echogenic stroma with whirlpool sign positive. And she was referred to SWIMS for further evaluation. Then MRI was done here. I will be sharing the MRI, ma'am, now. This is a T2 axial sequence of MRI pelvis. It shows enlarged ovary, which is shifted from its original position to into the pouch of Douglas, posterior to the ureter. The ovary shows multiple follicles which are arranged in the periphery, and there is mixed signal intensity in the central stroma. The pedicle is thickened, it is twisted, And we can see few serpiginous flow voids in the twisted pedicle, which indicate the twisted vascular structures. There is also free fluid in the pelvis. Right ovary is in its normal position, and multiple follicles are noted in the right ovary. And the uterus is shifted towards the side of the torsion, that is towards the left side. On diffusion weighted imaging, there are few areas of hyperintensity which are noted on DWI images with corresponding hypointensity on ADC, which are representative of infarction. So this represents a non-viable ovary. This patient, she was diagnosed as a case of left ovarian torsion with hemorrhagic infarct. She was managed surgically. Intra-op findings were left ovary was enlarged, necrosed, and dark stained with multiple peripheral follicles with 2 loops of torsion and edematous thickened tube with hematoma. And as the ovary was not viable, left salpingo-oophorectomy was done. Now, present illness, presently the patient presented with right lower abdominal pain since 2 days, which is sudden in onset, intermittent type. It is associated with 3 episodes of vomitings. On examination, there was tenderness in the right iliac fossa with gouging. Mass was palpable in the right iliac fossa. Initially, ultrasound was done, then MRI was done for the confirmation. These are the ultrasound images which show enlarged ovary with multiple follicles which are noted in the periphery, and there is central echogenic stroma.
So now ultrasound images are not seen. Can you share it again, ultrasound images? Yeah. That is visible.
These are the present ultrasound images which show enlarged right ovary with multiple anechoic follicles which are noted in the periphery with central echogenic stroma. The uterus, as noted in the images, is normal and it is pushed towards the opposite side. I'll be showing the MRI of the present
Admission. During the present admission.
I think there is some problem.
No, sir. Maybe she is loading it, sir.
Okay.
The radiant viewer, she will be showing, because we thought if you scroll, it will be better than putting the static images.
Okay. Okay. Fine.
Sana? Are you able to show, Ma, Sana? Okay, thank you. So,
This is a present MRI scan, ma'am.
yeah, sure.
This is a T2 weighted coronal sequence which shows an enlarged ovary, which shows a central T2 hyperintense stroma and multiple follicles which are arranged in the periphery. The uterus is pushed to the opposite side. There is a twisted pedicle in the superior aspect of the ovary which shows serpiginous vascular structures with flow voids. The same findings can be appreciated on the sagittal sections also. This is the enlarged ovary with follicles. This is the twisted pedicle, and there is also minimal free fluid in the pelvis. On T2 axial sections, enlarged ovary can be seen with multiple follicles arranged in the periphery and central T2 hyperintense stroma. Twisting of the pedicle can be appreciated as the whirlpool sign. Left ovary could not be visualized as it is as left salpingo-oophorectomy was done for the ovarian torsion 1 year ago. On diffusion weighted imaging, there are no areas of restricted diffusion, indicating that arterial compromise has not yet occurred and the ovary is still viable.
Go to the presentation now. PPT. So here, if we can observe that previous first admission, there was diffusion restriction in the ovary, and that was unviable. This case, second admission, there is no diffusion restriction, suggesting it as a viable ovary. Go to the Sana presentation. How they have managed it, you can show them.
Presently, the patient was operated, and intraoperatively, the right ovary was bulky with multiple cysts in the periphery, and there was one loop of torsion, and the fallopian tube was edematous. As the ovary was still viable, laparoscopic right ovarian detorsion was done, and the ovary was saved. Only oophoropexy was done, and the ovary was fixed to the right pelvic wall, ma'am. Due to as we were able to image with timely, we could save the right ovary this time, ma'am.
Yes, ma'am. You can go to the next slide, discussion.
Coming to the definition of the torsion, torsion is the torsion of ovary is partial or complete rotation of the ovarian vascular pedicle, which results in obstruction of the venous outflow and the arterial inflow. The predisposing factors for ovarian torsion or torsion can occur in abnormal ovaries as well as in normal ovaries. In abnormal ovaries, most often it is due to large heavy cysts and cystic neoplasms, benign mature cystic teratoma being the most common. The other cysts like large hemorrhagic cysts, cystadenomas and malignancies can also cause torsion of the ovary. Large cystic ovaries as seen in ovarian hyperstimulation syndrome can also be a cause for torsion of the ovaries. Normal ovaries can also undergo torsion. This is very unusual, but is more common in adolescents. The causes include a markedly mobile fallopian tubes or the mesosalpinx, elongated pelvic ligaments, fallopian tube spasm, strenuous exercise, abrupt changes in intra-abdominal pressure. There are also a few protective factors which render the ovaries relatively immobile, such as the adhesions which develop after pelvic inflammatory disease, endometriosis, or malignant neoplasms. Studies have shown that left ovary is less likely to undergo torsion due to the presence of sigmoid colon, which protects the ovary from torsion because the space will not be available. Coming to the supports of the ovary, suspensory ligament or the infundibulopelvic ligament. This suspensory ligament has the vascular structures of the ovary, ovarian artery and the vein and the lymphatic structures, and the broad ligament, ovarian ligament which connects the ovary to the body of the uterus, and the fallopian tube. Ovary has dual blood supply, one from the ovarian artery and the other from the uterine artery. Coming to the pathophysiology of torsion, initially there will be a suspensory ligament twist which causes the compression of the ovarian vein and the lymphatics, which results in massive enlargement of the ovary and the vascular pedicle. At this stage, the ovaries are still salvageable. Then as a further progression, the arterial supply will be compromised and there results ischemia and infarction. After this, the ovary will be non-salvageable and not viable. Coming to the graceful ultrasound features, a unilateral enlarged ovary which is more than 4 centimeters in size, flipped ovary sign, that is, ovary is displaced from its original position towards the midline. Most often it is displaced superior to the fundus of the uterus or into the pouch of Douglas. String of pearls sign representing the peripherally arranged cysts or follicles. There may be a coexisting mass within the ovary, free fluid in the pelvis, and the twisted vascular pedicle. It is a rotation site of the vascular pedicle and it appears as an echogenic round or beak mass with multiple concentric hypoechoic stripes. There may also be local probe tenderness. Coming to the color Doppler findings, on Doppler, the findings are variable. There may be either decrease or absence of venous flow. Classical finding is the absence of arterial flow. However, the presence of arterial flow does not rule out torsion. Doppler helps in determining the viability. Non-viable twisted ovaries will demonstrate absence of central venous flow. The presence of central venous flow represents a viable twisted ovary. Whirlpool sign is a visualization of circular or coiled vessels in the twisted vascular pedicle. This image represents the enlarged ovary with multiple anechoic follicles which are arranged in the periphery, giving the appearance of string of pearls. On color Doppler imaging, there was no color flow in this torched ovary, representing that it is not salvageable. This is an ultrasound image which shows a snail shell appearance of the twisted vascular pedicle, which on color Doppler shows a whirlpool sign, which represents the twisted vessels. Coming to CT and MR findings, the findings include an enlarged ovary, uterine deviation to the side of the torsion, smooth wall thickening of the twisted adnexal cystic mass, and fallopian tube thickening, peripheral cystic structures in the ovary, and ascites. Uncommon findings include hemorrhage in the thickened fallopian tube or hemorrhage in the twisted ovarian mass and hemoperitoneum. The presence of hemorrhage in the ovary and in hemoperitoneum represents the presence of hemorrhagic infarct, representing that the ovary is not viable. This is the axial contrast enhanced CT image which shows a triangular mass of soft tissue which is located adjacent to the enlarged ovary. The same patient on MR imaging showed that this triangular mass corresponds to the twisted vascular pedicle. This twisting occurred due to the presence of a benign appearing right ovarian mass. This is the enlarged left ovary which is shifted into the midline into the pouch of Douglas with the twisted vascular pedicle showing the whirlpool sign and the shifting of the uterus towards the side of the torsion. The differential diagnosis for torsion include large hemorrhagic ovarian cyst, serous cystadenoma, ovarian hyperstimulation syndrome, pedunculated degenerating fibroid, and massive ovarian edema. Ovarian hyperstimulation syndrome, it occurs when ovarian stimulation is done using beta-HCG in treatment of infertility. This is the ultrasound image of 37-year-old woman who was 11 weeks pregnant following ovulation induction, and she presented with right iliac fossa pain. We can see an enlarged ovary with multiple follicles arranged in the periphery and central echogenic stroma. The differentiation from torsion is that in ovarian hyperstimulation syndrome, most often bilateral ovaries are bulky with follicles arranged in the periphery, whereas torsion is more commonly unilateral. The other differential is a degenerating leiomyoma. In this case, this is a mass degenerating leiomyoma with the ovary, which can be seen separately from the mass. In case of serous cystadenoma, the ovary can be there is a serous lesion which is noted in the ovary. However, on color Doppler, there is normal arterial flow in the ovary, representing that the ovary is normal and not torsed. Hemorrhagic ovarian cysts are also a differential diagnosis, which appear as well-defined lesions with echogenic debris within the cystic lesions. Sometimes a clot may also be noted with retractile echogenic debris within the cyst. Thank you, ma'am.
So to conclude, this case shows us two extreme patterns of ovarian torsion. In the first presentation, initially 1 year back, when she presented, she had a long history, more than 5 days history. So at the time of presentation itself, she had a hemorrhagic infarction of the ovary. So that time they could not save the ovary. But in the next time when it happened, she had come to the hospital immediately within 2 days. So this time it was still in the stage where we can save the ovary. So to conclude, basically we should be knowing the imaging appearance of ovarian torsion for early intervention so that we can save the ovaries. Thank you, ma'am. Any questions, ma'am?
Madam, there is one doubt. No?
Yes, sir.
In each case, no, actually it was presented like the uterus was shifted to the side of pathology. So
Yes, sir.
In the first case, actually the uterus was
Sir, this is same patient, sir. Same patient.
Same patient. In two different situations. Yeah.
Yes, sir. Yes, sir.
The uterus it was displaced to the same side or towards left. Does it carry any significance? The shifting of the what I mean, shifting of the uterus in case of torsion ovary, whether something is related or.
Sir, in the first setting, whatever literature says, it is seen similarly, sir. Like same side, it is shifted, sir. But in the second time when she presented, there was no ovary the left side, sir. And whatever is this enlarged ovary was there, that was pushing the uterus to the opposite side, sir.
That was the opposite side.
Opposite side, because there was no other ovary or any structure the other side, sir, left side. So that's why I think second time when she presented, there was no shift to the same side. It was shifted to the opposite side.
No, my question is, when there is torsion ovary, is it something like that the uterus will be shifted to the same side, to the affected side?
Yes, sir, because of the twist of the pedicle, it will usually, yes, it should get shifted to the same side, sir. It should get shifted to the same side.
Okay. Yeah.
Any other points?
There is a question asked to show the ultrasound image once more. Somebody has asked.
Yes, ma'am. She will show. Sana, can you show in your presentation our case?
Yes, ma'am. Yes, ma'am.
Ultrasound image.
I want to know how was the vascularity in this patient, in this case? Sana?
Within the Doppler, ma'am?
Yeah, the same patient. Because you have done Doppler, you know.
Yes,
was done. If the vascularity is maintained only, they will do, no? That's why I asked.
Yes, ma'am.
On Doppler, we could not properly evaluate the vascularity, ma'am. However, on MRI, there was no presence of restricted diffusion. So, hemorrhagic infarct was ruled out, ma'am.
Okay.
This is present.
Share it, huh? Share your screen. We are not able to see.
And one more question they've asked, significance of the triangular mass. She had shown one image with the triangular mass.
Yes, from the textbook, I think she has shown that triangular mass, ma'am, that represents twisted pedicle and the non-contrast CT.
Yeah.
So if you see like a cap, you can consider it as a pedicle, ma'am. If you give contrast, that pedicle will show some.
Yeah, if there is a long pedicle, what happens is the ovary can be in the pelvis or it can be in the hypergastrum also. It can wander. So in this case, I think because a long pedicle, the ovary was in the pelvis. That's why when it got engorged, the uterus got pushed to the left side and anteriorly also.
Explain, Sana. What are their findings, your findings?
On ultrasound, the presence of an enlarged ovary was noted, ma'am, with peripherally arranged follicles, which are appearing as anechoic structures in the periphery, and the central echogenic stroma was noted, ma'am. And
And Sana, do you find this so much echogenic rim in an ovarian follicle?
normally it is not found, ma'am, but in cases of torsion, presence of a well-defined circular echogenic rim is the classic, ma'am.
Okay.
No free fluid, no hemoperitoneum, no, this second admission.
Yeah. Yeah, no free fluid is seen also. Yeah,
Yes,
okay. Okay, thank you, Sana, for the wonderful presentation. How is the patient now? Any follow-up?
Well, she's doing well, ma'am, and there is no, presently she doesn't have any pain also, ma'am.
Okay, very good.
She is one of our nursing student, ma'am.
Oh, okay, okay. Okay.
Now,
thank you so much. We'll go to the second case.
Yes, ma'am. I'll request Sana to Manasa to present second case.
Okay.
Manasa?
Yes, ma'am. Good evening, ma'am. Good evening, everybody.
Start presenting, ma, Manasa.
She's sharing a screen.
Yes, ma'am.
Good evening, everybody. I am presenting a case of 47-year-old perimenopausal woman presented with complaints of nausea, fullness, and bloating of stomach. On examination, there was an ill-defined immobile mass in the pelvis on both sides, which was extending into the lower abdomen. She was evaluated with ultrasound abdomen outside and which showed complex cystic ovarian mass, and she was referred for further evaluation to our institute. Her past menstrual history was uneventful, and here on evaluation, routine blood investigations were normal. Serum urea creatinine were normal. Her serum CA125 level was 436 units per ml, and serum CA was 0.75 units per ml. CECT abdomen pelvis was advised in view of raised serum CA125. I would like to share the case video.
Hello? Any net problems, Soumya?
No, ma'am. Maybe they're sharing, opening that radiant viewer, ma'am. Little 1 second it will take, ma'am, time. Radiant viewer to load all the images, it takes time. Manasa?
Yes, ma'am. Just 6 seconds, ma'am.
Okay, okay, ma'am. Keep on talking then. Something.
Yes, ma'am. On examination, we had a contrast CT abdomen done.
What was it showing? Contrast CT?
It showed a multi-lobulated, well-defined It showed multiple multilobulated cystic lesions with enhancing thin septations in both the ovaries, which was extending into lower abdomen.
Not yet loaded, I think. Ma. Okay. We'll wait just 2 seconds.
With eccentric nodular component in the
Full case was not loaded, I think. Ma. Only partly it came. Again, you can try to load it.
Yes, ma'am. Trying. Still did not load. I did not share. I'm sorry for the delay. We are ready now.
Yeah, you can show it. Ma. Show it.
The axial contrast enhanced CT abdomen. Showing minimal free fluid in the left paracolic gutter. Mesenteric lymph nodes in the abdomen. These are bilateral, multilobulated, well-defined. Well-defined mixed density lesions, predominantly cystic, on both sides within the pelvis, extending into lower abdomen. There is enhancing walls with eccentric solid component within the both lesions. However, bilateral ovaries are not visualized separately. Uterus is noted in the midline and is normal. There is extension of the lesion into the pouch of Douglas. From the left side, the right lesion is noted extending to the pouch of Douglas. This is the lesion extending into the pouch of Douglas. This is the right ovarian lesion, and this is the left lesion. There is minimal free fluid in the right iliac fossa. The lesion, the enhancing portion of the enhancing solid component of the lesion is seen closely abutting the sigmoid colon loop here. There are few subcentimetric lymph nodes in the para-aortic and in the mesentery. These are the lymph nodes. One large lymph node in the retroperitoneum is noted on the right side. There is no significant mass effect by the lesion, but however, there is focal abutment of the sigmoid colon.
Go down, ma. Uterus and other things. Little more. Yeah. It's not loaded, I think. That's why you're not able to see. Any other findings?
There is a nodule, ma'am, in the posterior left lower lobe posterior segment.
Lung window. Any other findings in bones, ma'am?
Bones are normal, ma'am. This is the lung nodule. This is the lung nodule in the left lower lobe posterior segment. The rest of the lung fields are normal. The bones are normal. Uterus is normal. There is only minimal ascites. However, there is no extension of the lesion into the peritoneum. Bilateral subdiaphragmatic spaces and the liver parenchyma and surface of the liver are normal. Ovarian masses are usually...
Yes, ma'am. Continue.
Ovarian masses are usually either solid or cystic. Solid masses...
What was done for this patient, ma'am? Explain how it was managed.
Then patient was advised ultrasound-guided biopsy, and ultrasound-guided biopsy was done from the solid component of the lesion. Histopathology was given as papillary serous cystadenocarcinoma. The patient was then taken up for debulking surgery with staging laparotomy, and TAH and transabdominal hysterectomy and bilateral salpingo-oophorectomy was done. Histopathological examination of the specimen was reported as low-grade carcinoma, serous type. Solid ovarian tumors can be either solid or cystic. Solid tumors can be either homogeneous or heterogeneous. When homogeneous, they can be uniformly filled with blood. If the component within the ovaries is blood, then it is endometrioma. If it is fibrous tissue, it can be either fibroma or Brenner tumor or fibrothecoma. If it is heterogeneous, it can be either fat or non-fat. Fat, it is matured teratoma, dermoid. If it is non-fat, it is either immature teratoma, granulosa cell tumor. If it is cystic, like in our case, it can be either unilocular or multilocular. When unilocular, we further look for the presence of solid component. If there is solid component, then we diagnose it to be the cystadenocarcinoma. If there is no solid component, it can be either simple cyst or cystadenoma. When it is multilocular, we look for the presence of the septations and how the septations are. If they are few and they are thin septations, it can be either cystadenoma or borderline tumor, or it can be an inflammatory mass. If in the multilocular lesions, if it is cystic lesions, if there are nodules and vegetations, it favors more malignant lesions. There is cystadenocarcinoma or endometrioid carcinoma or clear cell carcinoma. Ovarian tumors which are bilateral are mostly due to either serous cystadenocarcinoma or metastasis, Krukenberg from stomach, colorectal carcinoma, lung or breast carcinoma, or mature teratoma, which can be either spreading from one ovary to other, or presence of concurrent lesions. Serous cystadenocarcinoma is a thin-walled unilocular or multilocular tumor filled with serous fluid. This tumor is very common and may mimic a physiological cyst or occasionally an atypical mature cystic teratoma that lacks the characteristic eccentric neural nodule. Bilaterality and peritoneal carcinomatosis are seen more frequently in serous than in mucinous cystadenocarcinomas. Presence of a entirely cystic differentiation of benign and malignant epithelial neoplasms can be done with the help of their composition, wall thickness, and internal structure, or presence of ascites or peritoneal disease. Components, when it is entirely cystic, it favors benign lesion. When the septation, if it is septated and the septations are thin, that is less than 3 mm, and the wall thickness is less than 3 mm, it favors a benign lesion. Internal structures, when they are absent and when there is no ascites, it goes in favor of benign lesions. When there is a large soft tissue mass with necrosis, or when it has a thick wall, or when there are papillary projections, which are usually enhancing mostly, and peritoneal and anterior to uterus if there is ascites, or when there is peritoneal implants or pelvic wall invasion and adenopathy, it favors malignant tumor. CT of the abdomen pelvis is the first line imaging modality for staging of ovarian malignancy, and it is useful in selecting treatment options, and it is used in assessing disease response in ovarian cancer. The staging CT provides disease distribution, disease burden, and is imaging surrogate for surgico-pathological figure staging. This helps in the evaluation of spread of the disease. The pelvic disease is initially assessed for the size of ovarian masses, usually less than 10 centimeters, it favors the benign lesion, and more than 10 centimeters, it favors the malignant lesion. Assess the uterine and adnexal invasion, peritoneal reflections of the anterior and posterior pouch of Douglas for the presence of pararectal and sigmoid nodules. The one here in the yellow signifies that it is not resectable, but however, in the presence of a surgically skilled people, it can be resected to debulk and reduce the tumor burden and further continue with the chemotherapy. That is the presence of rectal and sigmoid diffuse serosal wall or luminal invasion, or presence of vascular side wall invasion, or presence of ureteric invasion is a non-resectable tumor. When there is bony and muscular pelvic side wall invasion, or when there is diffuse presacral disease, it totally goes against the resectability, and prior chemotherapy is given before going to the surgery. And other the areas which are assessed in staging of ovarian cancers are: right upper quadrant is assessed, that is the subdiaphragmatic disease, diffuse spread is assessed. When the diaphragm is more than 2 centimeters thick, it should be suspected for the presence of a plague disease. And porta hepatis of the liver and lesser sac, falciform ligament, Morsing's pouch, and gallbladder fossa are to be assessed for the presence of disease. Parenchymal liver mets or the invasive surface implants on the liver go against the resectability. Right paracolic space assessment is done for the peritoneal and serosal disease along the ascending colon, and the appendiceal mass is also assessed. Presence of gastrosplenic ligament, lesser omentum, gastric and duodenal serosa can go against the resectability. Look for the presence of greater omental disease, like presence of standing or nodular diffuse omental caking. Assess for the involvement of transverse mesocolon, mesenteric disease, diffuse large volume disease, or root of small bowel mesentery involvement. Lymphadenopathy, pelvic, abdominal, and retroperitoneal lymphadenopathy, whereas presence of high retroperitoneal nodes at or above the celiac axis goes against the resectability. In our case, the disease involvement of the serosa was noted, but serosa of sigmoid colon was noted. However, debulking of the surgery was done. Only ascites with disease, there was no involvement of root of mesentery. There was only subcentimetric lymph nodes in the retroperitoneum. There was no involvement of the liver or liver surface. For prediction of non-resectability, CT plays a critically important role in identifying lesions more than 2 centimeters at the root of the mesentery, gastrosplenic ligament, lesser sac, or at the porta hepatis, falciform ligament. Presence of paracardiac nodes and lung parenchymal nodules, and also in detecting high retroperitoneal lymphadenopathy, presacral and extraperitoneal disease, and pelvic side wall invasion. These are used. Presence of these lesions goes against non-resectability, and CT plays a major role in identifying the disease before taking the patient for surgical debulking. The most important limitation of CT is its inability to demonstrate small volume extra ovarian, that is less than 5 mm deposits on either bowel serosa or in the mesentery and in the peritoneum, especially when there is absence of ascites. This may necessitate the complementary role of laparoscopy in pre-surgical evaluation of the ovarian cancer. Thank you. Ma'am, any questions, ma'am?
There's a question. Do we have to add all these negative points while reporting a case of malignant ovarian mass? Can you hear me?
Yes, ma'am. We need to report the negatives, ma'am, so that it can help the surgeon in planning for the debulking, ma'am, in reducing the amount of lesion before going for chemotherapy.
Madam, one thing, just a small comment. That is, when there is some peritoneal disease now, there actually you can tell that, say, the deposit is there in the gastrosplenic ligament region, deposit is there in the subcapsular region, or deposit is there in the mesentery or omental deposits like that, if it is there. So if no deposits at all, then you don't have to say that, so it is free, it is free, it is free. You don't have to say. So there is no evidence of any peritoneal disease. So that's enough actually. You don't have to pick each area, each anatomic area and say there is no deposit, no deposit. Actually, that is not necessary. That is number one.
Okay.
And second point, I want to know is, so here actually is a bilateral ovarian malignancy. Bilateral ovarian malignancy without any peritoneal disease. Am I right?
Yes, sir.
Sir, some small lymph nodes are there, sir, but
retroperitoneal nodes.
yes, sir, small lymph nodes are there, sir.
Okay.
Only one node was a little sizable.
There are certain situations now where actually we would be in trouble. So whether to go for biopsy or not. Suppose the capsule is intact, there is no peritoneal disease. It appears stage 1. Then do we go for biopsy? Suppose the clinician asks for biopsy, then what to do? The thing is that actually biopsy is indicated only when the clinician plans to, or the oncologist plans to go for pre-op chemo. That is neoadjuvant chemotherapy. At that time only. Otherwise, if it is resectable, if they don't have to go for plan for chemo, if they plan for upfront surgery, in that case, actually, they can straight away go for surgery. We don't have to do biopsy. Here, of course, okay, no problem. Here are some retroperitoneal nodes were there. Otherwise, no, what will happen now? Stage 1, actually, by doing biopsy, anyway, there will be some spillage of fluid into the peritoneal cavity now. So automatically, it will become 1C. So that we can avoid. So we can just tell the clinician. So otherwise, we have to make sure that actually this is very much indicated. Biopsy is very much indicated. Okay. And one more point, just I want to know whether, is there any role for MRI in ovarian masses? What do you think? Because nowadays, most of the time, we will see, if especially when the patients are coming from periphery, they used to bring MRI for ovarian lesions. So what's your...
Sir, in our place, routinely we are not doing, sir, MRI. Basically, it is the CSCT only we are doing, sir, abdomen and pelvis. And in some cases, maybe sometimes they're going even for PET CT, but not MRI. We're not getting that much indication.
The thing is that many times now we are actually getting people with a MRI. They are actually MRI done from outside, and they are bringing the MRI.
Yes.
And in MRI, actually reading MRI, it's very difficult to say whether some small omental deposits are there. So that is going to be missed. So it's ideally one thing, ultrasound. Ultrasound, we can characterize the lesion, ovarian lesion, and then for staging purpose, just go for CT. I think that's enough. Of course, PET, okay. So if you expect some extra abdominal metastasis on all cervical nodes and all, okay, PET. Otherwise, MRI, what about madam? Is there any particular?
No, I prefer, but nowadays most of the gynecologists in our place prefer MRI than
MRI.
They send for MRI than CT because they feel the characterization is more in MRI than CT. But as you said, the metastatic deposit all can be better appreciated in CT, contrast and CT than MRI. Okay. Because there is ORAD's lexicon for MRI. There is no ORAD lexicon for CT. That's all.
Maybe, ma'am, it is like when we have a diagnostic dilemma, whether it is a benign or malignant lesion, characterization purpose, I think we can do MRI. But for staging and follow-ups, I think we can do with CT.
Yeah, that's best.
Yes,
That
ma'am.
is before giving any chemotherapy, they send. Then follow-up also they give for CTs, oncologist. But
Yes, ma'am.
gynecologist send for MRI. That is the difference here.
Now, with madam's permission, can I ask a small question to Dr. Sana?
Yes, sir.
No, one small thing.
Yeah, you can ask. You can ask.
Yeah. When, like this one, ovarian malignancy is there now. Pakka ovarian tumor is there. So there actually you are not seeing any other extra ovarian deposits except for a small wall thickening along the posterior wall of the ascending colon. Okay, thickening along the posterior wall of the ascending colon. So how will you interpret this lesion as that is thickening? Again, I'm repeating it, thickening of the posterior wall of the ascending colon. So ovarian tumor is there on one side and thickening of the posterior wall of the ascending colon on the other side. So how we can connect these two findings now?
Must be Krukenberg, sir,
Dr. Sana?
because metastasis, it can be metastasis from the colorectal carcinoma, because when there is a posterior wall thickening and there is bilateral ovarian tumors, first suspicion should be towards the Krukenberg metastasis. But Krukenberg mostly are solid rather than.
No, it's a small nodule,
They can-
small focal thickening only. So just you mentioned earlier, no, so there are so many deposits. Deposits can occur at so many places now. So like that, can you put this thickening as some deposit at some place? I mean, so whether that is possible, primary ovarian with metastatic deposit, that is possible.
Yes, sir, that can be also a possibility, sir.
Okay. That is what I want to know. That the thing is that see the ascending colon is actually retroperitoneal structure. So there actually the peritoneal lining is only over the along the anterior wall of the ascending colon now. So here actually you are seeing thickening along the posterior wall. So there is no serosa. So there is no peritoneal deposit cannot occur there. So in that case, actually you have to suspect first primary, second primary. So concomitant disease can occur. Ovarian malignancy with colon malignancy. So you have to suspect second malignancy as first possibility because actually there is no cirrhosis there. You got the point.
Yes,
That
sir.
is the anatomy. So that is why as the posterior wall. Anterior wall, suppose you are seeing, again, you are in doubt whether it could be colon mass or deposit, serosal deposit. But since there is no serosa posteriorly, if you see a wall thickening along the posterior wall, then first you have to take this as the second primary. Okay, thank you.
Yes, sir. Even in our practice also, I had seen a similar case, sir. On follow-up, patient has developed this type of lesions, sir, in the colon, right-sided colon. So, CF ovary patient developing right-sided colon lesion. Second primary, sir, it was. Second primary. Thank you, sir, for your inputs.
Yeah. It was really a very good presentation and the case discussion went out very well. Mainly the ovarian staging is very important in this for the oncologist as well as for the surgeon who's doing the case. So in our report, we have to give the staging, and when we do ultrasound, better to give ORADs to the gynecologist so that they will refer us for either CT or MR, whichever is which favors. But we prefer contrast CT. That should be specifically told to the gynecologist. But nowadays, PET CT is also done to find out metastasis elsewhere, and that is a point we should know. Thank you so much for the wonderful presentation, Sana and Manasa. I take this opportunity from Kerala IRIA to thank Dr. Vijay, who is from Sri Venkateshwara Medical Institute of Science, Tirupati, who has helped me to present this case and make this day wonderful by presenting their wonderful cases. Thank you so much, Dr. Vijay. I thank Dr. Venu also, who's our academic chairman, who was coordinating the session throughout 1 hour, and he has discussed the case very well. I thank you, Dr. Venu. And I also thank the Kerala IRA secretary and the program coordinator for making this session and continuing the session. I thank the MedPiper team also for giving us a good platform.